Hello, everybody. Dr. Al Heuer here, Terry Shenfield's partner in A&T Lectures, and this particular lecture is going to focus on consequences of untreated obstructive sleep apnea, more than daytime somnolence or sleepiness. So, probably like many of you, when I first came into the field of respiratory care, if there's any nurses, when you guys maybe first became nurses or sleep technologists, if we have any of you out there, basically thought that obstructive sleep apnea was, if it was untreated, it was more of a nuisance type of deal. And as I started to, teach more in respiratory care, do some writing and, textbook chapter writing and things along those lines, I was able to discover that it actually, it's actually much more than that. And this presentation is really aimed in that particular direction. We spend a little bit of time going over, some of the more traditional, well understood consequences. But really a chunk of this presentation is really dedicated to some of those consequences that are less well understood. And then we kind of wind up with some of the better news that with treatment, some of these lesser well understood consequences can be addressed, can be reversed in many cases. Also going to spend a little bit of time talking about some of the newer treatments that are out there. So a little more specifically, some of the learning objectives. We'll briefly define and describe apnea and look at both obstructive sleep apnea and a brief mention of central sleep apnea in order to make that distinction between obstructive sleep apnea or OSA and central sleep apnea. Describe some of the physiologic characteristics of obstructive sleep apnea, review again the more commonly understood consequences, and then spend some time doing a deeper dive on some of the lesser well understood problems that can occur. Review the impact of treatment. So again, 2/3 of the presentation is, oh man, this isn't good. But the last part of the presentation is really, there's some good news there. With treatment, a lot of these things can be either reversed or can be mitigated. We'll take a look at, in the interest of time, I have one case. We have longer versions of these presentations that go into more cases, and then provide you guys with additional resources should you want to drill down and learn more about these topics. So what is apnea and obstructive sleep apnea, and who cares? So depending upon which textbook you read, apnea is cessation of breathing in adults anyhow, cessation of breathing from a period of from 10 to 15 seconds or more. Obstructive sleep apnea is when the apnea or cessation of breathing is due to airway closure, often due to the collapse of the anatomy, the upper airway anatomy. Central sleep apnea is more commonly associated with an impaired signal from the brain or an injury, a direct insult to the pons or the medulla or the medulla oblongata, which are the breathing centers of the brain. Who cares? If this was a live lecture, I'd be saying, tell me you care, whatever. But obstructive sleep apnea has consequences, and it appears to affect millions of Americans, many of whom are yet to be diagnosed. So the good news is we've done a better job, or we're doing a better job of if you will, screening and identifying those that have obstructive sleep apnea. The bad news is we still suspect that there's many more who are yet to be diagnosed. And these consequences for those who are yet to be diagnosed, or those who are diagnosed but are yet to be compliant with their therapy, the consequences persist. And they represent a significant burden to the individual and their family, as well as to society and our healthcare system. May cause over, and again, this is an estimate, but it's not my estimate, $4 billion in additional and possibly avoidable medical costs. Diagnosis, so still the standard of care, the gold standard in diagnosing obstructive sleep apnea or even central sleep apnea is a polysomnogram. Some of the reference may be to a polysomnograph, also known as a sleep study. It's basically an all-night recording. It doesn't necessarily have to be the entire, 7 or 8 hours, but there's minimum standards that have actually been set by both Centers for Medicare, Medicaid Services, as well as private insurance companies that basically say that there's a minimum number of hours that the patient needs to have been actually sleeping and recorded during that time. There's several variables, or in some cases we call them channels that are simultaneously measured. And these include, but are not necessarily limited to, eye movement, airflow. So there's a thermistor that's situated, basically in the upper lip to sense airflow from the mouth and the nose. Respiratory movement, so chest excursion or respiratory movement. Believe it or not, leg movement, because there's also an association between restless leg syndrome and certain forms of apnea. EEG, which is electroencephalopathy. So that's actually looking at brain activity. And we'll talk just a little bit more. In the interest of time, really can't go into that in great detail, but a little more about the brain activity part of the sleep study. And then pulse oximetry as well as ECG or EKG, electrocardiogram. Obstructive sleep apnea. So this is really a simplified version of a graphic of what some of the channels that an individual might see in reviewing a sleep study for an individual. So the top line there is whether or not the patient is awake or asleep. That's that dichotomous, awake or sleep. Airflow in and out. So expiration, inspiration, and then you have actually effort. All right. So what's significant here is that there's effort. That bottom line there, that bottom graphic, there's effort throughout the entire cycle. Okay, so whatever period of time we're measuring here, let's just say, for argument's sake, it's 30 seconds. The patient is attempting to breathe throughout that period of time. However, in the middle portion, and literally the middle portion of the middle, if you will, the middle graphic, there's no airflow. So there's effort, but no airflow. So when you have effort, but no airflow, and the patient happens to be asleep, depicted in the upper line there, that would be the actual definition of obstructive sleep apnea, if that period of time exceeds 10 to 15 seconds, as I said earlier. Central sleep apnea, on the other hand. So what's primarily different here is that, again, that bottom graphic there, that in the middle portion, there's no effort. So that's suggesting that there's either some issue with the sleep centers of the brain and or the signal, getting down the phrenic nerve to the diaphragm and causing it to contract, drop, create a pressure differential, et cetera, et cetera. There's something that's inhibiting that actual signal getting down. The actual mechanisms themselves, I'm sure that many of you have seen some version of this depiction where the A, or the upper version there, is showing a patent airway, and B is showing it's barely patent. So you can actually see where one of those arrows is pointing, where it looks like the tongue has really dropped down, the soft palate and the tongue have really dropped down and relaxed to almost entirely occlude the airway. And what you're actually looking at there as well, many times it's just normal tissue, but it is just about entirely closed here. So the actual, some of these patients are sonorous, they snore. And the snoring is actually that soft tissue that's kind of vibrating. So there is air movement, okay, with some of these patients, but there's this snoring that happens. What you'll see many times as the condition progresses, gets worse, is that the patient will snore, and then there'll be this period of time where they're not breathing at all. And many times the bed partner, the husband, the wife, the boyfriend, girlfriend, whatever, will actually say, I wake up because I hear them snoring, and then they actually, I swear they stop breathing, and I have to actually shake them and kind of wake them up. There's no such thing, by the way, as a poster child for obstructive sleep apnea. This is actually Terry, my partner, Terry Shenfield, before he went to Weight Watchers. I'm totally kidding. This is totally untrue. That's not Terry. Looks a little like him, but not really. But if you were to take, folks that have demonstrably evident obstructive sleep apnea, you would say that probably 60 or 70% of them are severely morbidly obese. They're not all. So I'm not going to sit here and say that they all are, but you find that a higher percentage of them tend to have these. They tend to be men. They tend to be maybe kind of a bulky, maybe they're ex-football players who've really let themselves go, tend to have a short neck, maybe short in stature, et cetera. And that's true, again, of about 2/3 of the patients that have obstructive sleep apnea. So the commonly understood or known about consequences would include the top portion of the slide. And that is really, the subjective, the sleepiness during the day, the snoring when they're, at night, They may well be at higher risk for motor vehicle and or industrial accidents. And the motor vehicle accidents may actually, they may have a pattern that they've had a few of them. They've occurred during the day. There was not any, they weren't drinking alcohol. There was no inclement weather. There was none of those causes that sometimes are associated with motor vehicle accidents. There was nothing along those lines. No undue carelessness, and the patient may report that, I don't know, I just fell asleep at the wheel. Some of the objective or measurable indicators would be the actual cessation of breathing followed by a period of arousal, and the bed partner may well detect that. If there's any sort of pulse oximetry or any EKG or EEG change, equipment that's actually loaded up, what they will actually do in let's say a hospital or a clinic setting is, if the patient's staying overnight, not for a sleep study, but they're at high risk, they may actually do an overnight oximetry reading. So it may detect, both tachycardia and hypoxemia. The EEG changes would be more for, if now the index of suspicion is even higher, and now they have a polysomnogram that's being conducted. And in addition, what's actually happening as well that we now know is really associated with some of the occult sequelae, are the release of stress hormones with each arousal. So you say, well, I have 1-2 arousals, but some of these patients are having tens, in some cases, almost 100, but tens of occurrences each hour. So over the course of the night, they may be having, 100 or more of these, where they go apneic and then they're awoken suddenly, and then there's a stress hormone release. Okay, so we're going to refer back to that as we kind of, drill down on this more with the occult consequences. And some of those being neuropsychological sequelae, physical trauma. And really the physical trauma would be, again, operating heavy equipment, being behind the wheel of a car or truck or some sort of, heavy equipment. Metabolic derangements. So we talk about individuals that have, they have diabetes, or they've had diabetes, but it has abruptly gotten worse. Individuals that develop hypertension, or their hypertension has worsened concomitantly with worsening obstructive sleep apnea, and then various forms of heart and vascular disease. So these are the physical trauma we kind of knew about. There's a closer association now, but some of these other events and conditions are more closely associated with untreated OSA. Normal sleep cycle. So, again, this is an oversimplification, but in the interest of time, just to kind of go over this quickly, sleep is divided into 2 general phases: rapid eye movement, or REM, or non-rapid eye movement, or non-REM. And REM really represents the absence of electromyographic activity. So it's this rapid eye movement that's occurring along with this absence of electromyographic activity. It alternates with non-REM about every 90 minutes. What happens as an individual progresses through the night. So if they're sleeping, for instance, 8 or 9 hours, in those last few hours that they're sleeping, those 90-minute cycles will tighten up where they're closer to about 60 minutes. So really getting deprived of those last 2 or 3 hours of sleep can deprive the individual of a disproportionate number of REM cycles, which can be significant in terms of recovery of the individual, sleep recovery of the individual. Non-REM is actually separated into 4 cycles, but some of the books will take, if you will, stages 3 and 4 and lump them into one. So you have stage 1, slow eye movement, progressing all the way up to stages 3 and 4, which is slow wave sleep, also called delta sleep. And that's really the phase, really 3 and particularly 4, where breathing is reduced during this stage. And that's most commonly where the obstructive sleep apnea can occur. The caveat to that is there's cases where the individual sleep cycle is so fragmented that they don't even get into that phase. They don't get there. This slide is really just to kind of depict. It's not actually what's happening. It's really to show you the various stages of sleep. But really, what it's to show you is this supposed to be a regular circle, if you will. Okay, and there's these fractures or fragments that actually occur. In some cases, as I said, the upper left there, which is the deeper blue, that stage may not even occur. So the fragmentation may not just be in this fracturing, it may be incomplete with a cycle that the darker blue there doesn't even happen, or doesn't happen with each individual cycle. Results of fragmented sleep cycles is disruption of homeostasis. So again, this recovery time that that many of us benefit from each night. So in the duration of sleep, duration and number of each sleep cycle. So it's this quality of sleep. There's a commercial. It's for I think it's a mattress commercial. It talks about junk sleep. And it's about, well, you slept 7 hours, but it was junk sleep. You didn't recover from it. And it's actually a little bit of a funny commercial. At least on the East Coast, they've been starting to show that. And it's just I think about this lecture when I actually see that. And some of the patients that I've treated through the years that have actually talked about, yeah, I slept 6 hours last night, but I don't feel like I slept at all. Changes in circadian rhythm. Circadian rhythm is just your normal wake sleep cycle. And circadian rhythm can be actually interrupted even for some of our shift workers. Individuals that work night shift may be affected by that. Sleep, again, the sleep wake cycles, again, are interrupted. Insufficient cerebral recovery. So where the brain will file the events and knowledge that has been acquired, and events that have happened in the past, in the course of the past day, week, month, whatever, kind of file it appropriately, kind of organize. That's where dreaming comes into play sometimes, where it's the actual process of these thoughts and ideas and knowledge getting kind of more organized in the brain. But when individuals they have junk sleep, if you will, that is not allowed to happen, or not allowed to happen sufficiently. Multi-organ system fatigue, it's just, sleep allows the brain to recover, also allows the body and the organ systems to recover as well. And when sleep is interrupted, it does not happen the way it should happen. So let's take a closer look at some of the neurobehavioral effects or sequelae. So, talk about these daytime sleepiness. That's more of a traditional, or better understood consequence of untreated OSA. But again, some of the other neurobehavioral effects, a sizable effect on the ability to sustain attention. So some individuals who are, if you will, deprived of quality sleep, they have untreated OSA. The effect is less on reaction time and more on the quality of the performance. So let me be more concrete in this. So it might be that the individual was able to hit the gas pedal with the same amount of reaction time. The problem was they were supposed to be braking. So they hit the pedal in about the same amount of time, but the pedal they were supposed to be hitting was the brake pedal, and they hit the accelerator. Okay, and that may be an extreme example, but it may be operating this particular type of equipment. So you're able to actually, whatever it was, manipulate the settings on that, except the right lever wasn't hit on the backhoe. Okay, or on some sort of manufacturing environment, or some sort of a computerized environment where it requires some manual dexterity, where the wrong lever, the wrong key, and the keyboard was hit, sort of thing. Moderate to severe OSA negatively impacts memory and executive performance. And by executive performance, we don't mean like the C-suite, you're a vice president, whatever. We're talking about the ability for somebody to, number one, organize and manage their life, and organize and manage what they do professionally, and organize and manage. I don't mean to sound too utilitarian about this, but also organize and manage their relationships, whether it be professional relationships or relationships that they, told their spouse or their friend that they would pick them up at a certain time, or whatever, and they're forgetting more now, and it's not happening. There's also been a higher incidence of social impairment. So overall quality of life, there's these, if you will, measurement tools that are out there that are able to, with pretty good validity, have individuals rate their quality of life overall, as well as in certain domains. Okay, quality of life with job satisfaction, quality of life with relationship satisfaction, with financial, blah, 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 blah. And we know that individuals that have severe untreated obstructive sleep apnea tend to rate their quality of life lower than those individuals that do not. Diminished social functioning, so that is what it is. It kind of goes along with that quality of life, that if you're irritable, if you can't remember things, if you can't show up to pick up your friend at a certain place in time, that all those things are impacted. If frankly, you're just so tired that you can't, that you can't or don't want to go to a social function, that's also going to have, social consequences as well. High prevalence of minor psychiatric morbidity. So what we mean by that is even individuals that maybe have a slight predilection towards anxiety or depression, having untreated OSA can exacerbate it, can make it from, turn it from being a mild, if you will, condition to one that's, that's more significant. And what we have here is an ability, or actually multiple tools that are out there to actually measure, if you will, or quantify, the level of severity. And one of them is the multiple sleep latency test. Requires subjects to try to fall asleep during daytime nap opportunities lasting 20 minutes or less. And really the latency period is time from lights out to the onset of sleep. So individuals that have severe obstructive sleep apnea will have a fairly short period of time that they could fall asleep much more quickly. Problem is, it's not sustained quality sleep, but they're so deprived that they could fall asleep, just about anywhere from lights out. I had a friend that I worked with, and he worked rotating shifts, and he could fall asleep getting us a drink at the bar. If I'm sitting there, he really could. He swore he could fall asleep while he was walking, which is obviously not a good thing for all kinds of reasons. Trauma, accidents, just badness. It's spelled badness type of deal. But this particular multiple sleep latency test is really looking at specific measurement of the ability to fall asleep. And again, shorter time associated with more severe OSA. Now, again, it's if you took 1,000 individuals that had untreated OSA versus ones that didn't. It doesn't mean that if you fall asleep in 3 minutes, you have OSA. It just is a higher association with individuals who would fall asleep more quickly and having OSA. The Epworth Sleepiness Scale is commonly used as a subjective test of sleepiness, and it asks the individual to kind of rate, if you will, situational chance of dozing, rating it from 0 to 3. 0 being no chance, 3 being very high, and then they give you these parameters here. With a total score of 0 to 10 being normal, all the way up to 12 to 24 being abnormal, 24 being more abnormal than 12 or 14. Effects on trauma and accidents. This is one that is now becoming increasingly, where our awareness is becoming increasingly robust. I will tell you that the Teamster truck drivers are now required to have a sleep test, and with certain regularity. So an initial one, because it was recognized that that truckers were not only pushing themselves, but that they were falling asleep at the wheel, and they were having these accidents, and the accidents, were either resulted in death or morbidity, mortality to both the driver and the other people involved in the accident. There was a financial component, not just because of the morbidity, the injury to the individuals involved, but also the cargo they were carrying, the other vehicles that may have been involved in the accident, et cetera, et cetera. So there's a big emphasis on it there. So, and it's only been increasing. It wasn't always the case. They didn't always test Teamsters drivers or truck drivers, but now it's become pretty much standard of care with them. And then you've heard probably, at least on occasion, that some of the train engineers who are, if you will, driving these trains, that they have ended up falling asleep and bad things have happened, with the train getting into an accident, hurting people, killing people, and resulting in a lot of property damage. So the trauma is mainly secondary to the neurologic or the neurobehavioral effects. Sleepiness, difficulty concentrating, associated with higher degree of motor vehicle and industrial accidents. Very high incidence and cost with truck drivers, talked about that. Strong index of suspicion that the accident has atypical features. The individual fell asleep during the day, and then they're not a shift worker. It's not like when I worked nights and I was coming home at 8 o'clock in the morning. I was driving 8 o'clock in the morning when a lot of people are just have just gotten up recently and are driving to work. I was going home. So that's different. But talking about individuals where they're not working shift work and they're falling asleep, at 9 o'clock, at 11 o'clock in the morning, where there's witness difficulty staying awake or concentrating during the day. The patient is normally an outstanding worker or driver, and something's changed all of a sudden. And then other risk factors, including the ones we'll talk about regarding blood pressure and diabetes and things like cardiac conditions as well. So let's take a look at the metabolic effects, and really in particular diabetes and insulin resistance. So the mechanism of insulin resistance believed to be associated with that. When it is associated with OSA, they think it's associated with altered adrenergic function. Okay, direct effect of hypoxemia on the pancreas and glucose regulation, the release of pro-inflammatory cytokines that affect metabolism. And again, the physiologic results of insulin resistance. So you have hyperglycemia resulting from both an impaired insulin level responsiveness to glucose, as well as the decreased insulin effectiveness. So what happens is that insulin is not necessarily released at the correct times in response to glucose, number one. Number two, the insulin that is released is like defective. I'm being a little colloquial here, okay? That it doesn't work like it should. So it doesn't get released appropriately, and what is released doesn't work as well, just more in layperson's terms. And some of the evidence, there's a lot of evidence that's out there. Some of the earlier work, for instance, included Messler's work in and around 2000, or published in and around 2003. He and his colleagues studied 595 male patients, and they were referred to a polysomnogram. You guys can read, like I can this slide here, but basically they found that blood glucose increased with the severity of OSA. So the portion of the slide that's italicized here is really the critical finding. The other important part is this was not a small study. This was a fairly robust study. And again, almost 600 male patients, almost 500 patients had basically an apnea hypopnea index, AHI, that exceeded 10. Okay, so it was clinically significant. And the conclusion, basically focused on insulin sensitivity decreased with increasing severity of sleep apnea. The worse the sleep apnea got, the insulin sensitivity decreased. Okay, so this, the ability of the body to recognize, hyperglycemia and secrete insulin did not work as well. Punjabi did a review. So what Punjabi et al. Did was they looked at other studies that were done out there. And they looked in particular at habitual snoring and determined that it is associated with abnormal, basically fasting glucose and insulin values independent of age. BMI is body mass index. A higher body mass index, particularly one that exceeds 30, particularly exceeds 40, would be associated with more clinically significant folks that have overweightness and morbid obesity. Prospective data from two separate studies indicate that habitual snoring is associated with, again, more than a twofold risk of developing diabetes mellitus, DM, diabetes mellitus, over a 10-year period. So these close associations, and really were looked at, the multiple studies coming up with supporting very similar findings. And it also determined that several studies have suggested that a reduced oxygen saturation and apnea hypopnea index, a higher apnea hypopnea index, are predictive of glucose intolerance and insulin resistance. So what I'll say, not simply, none of this stuff it's trying to, maybe I'm making it overly simple, but what we now know that we didn't 20 years ago, or we didn't know very well 20 years ago, is that untreated obstructive sleep apnea is absolutely associated with, and may actually be causal, okay, with regard to diabetes, different forms of diabetes, whether it's developing it or if an individual has it, it becoming worse. Now let's focus our attention for a few slides here on hypertension. So let me just refer back to several slides back, and I talked about the release of stress hormones, okay? Stress hormones. So think of things like adrenaline. So think about the sympathetic side of the autonomic nervous system. we thought back, many of us, the respiratory therapists in attendance, can really focus on, the sympathetic side of the autonomic nervous system as being what we want to stimulate if we want to achieve bronchodilation. Okay, but we want to achieve it via stimulating beta-2 receptors. So we get this bronchodilation. If we do too much beta-1 or alpha, we get this fight or flight. Okay, so we get this, the vasoconstriction. We get the increase in heart rate. We get the, hyper awareness sort of thing. All right. Well, the unfortunate reality is that with each of these awakening cycles and the release of stress hormones, you get some of those same effects. You get vasoconstriction, you get increase in heart rate, you may get some bronchodilation, but you're getting a lot of alpha and beta-1, things that you don't necessarily want. And think about it. Individuals are supposed to be sleeping, recovering, okay? And they wake up and they have the exact opposite. They've gone from, they're supposed to be sleeping and they got this fight or flight thing going on, okay? So now with that vasoconstriction, we now have a better understanding that hypertension is one of the lesser well-known consequences of untreated obstructive sleep apnea. Let's take a look a little bit of the evidence. So there was what's called the Wisconsin Sleep Cohort Study. Okay, it still persists. It's still going on. All the cohort study is a study whereby they follow a population for a long period of time. And I'm not talking about months. Usually it's years, in many cases, decades. So they were following this in Wisconsin, following this group of individuals and kind of follow their habits and what they do for a living and their eating habits, smoking, drinking, and lions and tigers and bears, and basically what they determined. So these tend to be pretty robust studies. Cohort studies were some of the studies that helped us identify the risks of smoking, okay? The risk of eating too much sugar and consuming too much alcohol and fatty diets, et cetera, et cetera. So as part of the cohort study, they've determined that there's an increased risk for development of hypertension, HTN, in patients with OSA, obstructive sleep apnea, over a 4 to 8 year follow-up period. So this wasn't, oh, we're just going to do this thing and then we'll measure it in a month and then we'll call it quits, the study's done. This was following these individuals over a long period of time. So their outcome or one of their inferences or conclusions was severity of OSA increased the risk for development of hypertension, and it was significant. And it was independent of baseline hypertension, if they have it, age, gender, body mass index, alcohol, cigarette use. It was independent. It was an independent risk factor, hugely significant. The heart health study, looking at over 6,000 participants, and they're really looking at, heart health, but they were in the process of that, they're looking at, smoking, diet, all this stuff. They're also looking at, individuals that may have, under or untreated obstructive sleep apnea. And this study determined that there's an elevated risk for hypertension with individuals who have sleep disordered breathing. So think of sleep disordered breathing as OSA light. So we know that, let's say their apnea hypopnea score is not as high as it would be in OSA, but it's not normal. So they determined that there's an association between sleep disordered breathing, hypertension, regardless of age, regardless of gender, ethnicity, BMI, et cetera. So really strip those things out. These were significant findings. Cardiovascular disease. So even though hypertension is not the same as cardiovascular disease, there's certainly some overlap there. But we're looking at abnormalities associated with OSA may contribute to the initiation and progression of cardiac and vascular pathology. So again, this sympathetic tone activation, vasoconstriction, tachycardia. Really kind of talked about that in the preceding few slides. Okay. On top of that, you also have this endothelial dysfunction. So you have increased levels of endothelin with untreated OSA, increased levels of endothelin, which may lead to sustained vasoconstriction. So again, take this out of the technical garb, right? And so what happens is you have these repeated cycles of awakeness and release of stress hormones, okay? And over some period of time, so you have the body basically says, you're turning the on-off switch on and off so often, I'm just going to stay on, meaning I'm just going to stay constricted, all right? On top of that, you have this increased level of endothelin, okay? So, and again, it may be the increased level of endothelin may be caused by, well, the on-off switch, I'm just going to stay on and we're just going to release a high level of endothelin all the time, and we're going to remain vasoconstricted. Now that's kind of like the lay explanation, but that's pretty much what's happening, or they postulate, okay, or theorize that's what's happening. In addition, so you have now a third component here. So in addition, you have vascular oxidative stress. We have the production of free radicals, okay, and then you have, associated with the free radicals, you have vascular wall ischemia and reperfusion injury. Okay, these free radicals, they result in, if you will, cellular mutations. You have vascular wall, again, ischemia, reperfusion. So you have these abnormalities that can form in the vessels as well. And further on top of that, increased coagulation. So you think about, well, you got vasoconstriction because of sympathetic tone activation, further vasoconstriction because of endothelin. And now we have this vascular wall injury, okay, which can result in these, if you will, just sores, or these little portions of the inside of the vessels that can be harbingers of plaque. And then furthermore, you have increased coagulation. So you get patients that could be at extraordinarily higher risk for things like myocardial infarction and stroke. Further, if you will, disconcerting fact. So cor pulmonale. Cor pulmonale is right heart enlargement secondary to pulmonary vasoconstriction, more commonly associated with like COPD. Patient has COPD, it's gotten clinically significant. Their ventilation has dropped off because now they're hyperinflated. They can't exhale properly, et cetera. They have maybe Bullous disease. They have loss of elastin, et cetera. But then what happens is the body will actually constrict those vessels, saying, well, the ventilation isn't as good, so I'm going to reduce the perfusion in order to kind of equilibrate the VQ. Okay, that's a kind of a dangerous combo, because now you have hypoventilation that's associated with the OSA. You have concomitant pulmonary vasoconstriction, which is not due to COPD. It's just due to the fact that the patient has these repeated periods of hypoventilation or cessation of breathing altogether. So you have vasoconstriction. Now you have the right heart preload. The force with which, or the if you will, resistance with which that right heart has to beat against is greater, because you now have the vessels that are constricted. You then develop right heart hypertrophy, and it can actually eventually progress to right heart failure. All right, so another aspect of the cardiovascular sequelae. And this is just showing, a depiction here of the right side of the heart, where that cross-sectional thickness is supposed to be, of the right side is supposed to be less, thinner. The right cross-sectional wall of the heart, particularly the right ventricle, is supposed to be thinner than the left. This particular one is actually showing that, it looks to be about the same, crudely put, about the same, which you'd think, oh, well, that's good. It's not good, because it affects a lot of things, including it affects the chamber size. It affects the efficiency, diminishes the efficiency. It also affects the conducting pathway. Okay, that causes the heart to actually be the action potential. So it's not a good thing. Right heart hypertrophy can lead to right heart failure. It's not a good thing. And in this case, you think about the underlying cause of their etiology can be obstructive sleep apnea. Heart disease and vascular disease. So you have Marin, who basically, followed a population observational study over 10 years. Looked at 377 of the individuals that were followed were snorers. Okay, they snored. They reported significantly snoring. 403 patients with untreated OSA. And so you can kind of get the breakdown here. On the lower left there, the italicized part is saying what the findings were, and the outcomes were, patients with untreated severe OSA were 3 times more likely to have myocardial infarct or stroke. Okay. And again, it wasn't 10 subjects. It wasn't 50 subjects. It was many, many subjects that were followed over a long period of time, right? On the right-hand side of this slide, you have Milliman, prospectively monitored. So this was a smaller study, but it was designed in advance. They followed these 54 patients with both coronary artery disease, okay, and OSA. And if it's okay, I'm going to kind of skip down to the outcome here, because the outcome was that cardiovascular death, acute coronary syndrome, and hospitalization for heart failure, or need for, if you will, a open heart surgery, coronary artery revascularization, was present in 24% of the treated patients versus 58% of those who declined OSA treatment. Okay? So this was a smaller study, in all fairness, all right? But it's a study that was specifically designed to look at this, and it really determined that there's something there. When you combine this sort of a study with what Marin did following these patients over a long period of time and the other work that's been done, it's pretty pervasive. So now, again, we've come to the point in the presentation where, a lot of bad news and a lot of, depressing news. It's the reality of things. I always believe that it's better to know about things than not. But there's treatments involved, and some of the pathophysiology is actually reversible. So the mainstay is still BiPAP. Okay, CPAP, BiPAP, basically non-invasive positive pressure ventilation. Other treatments would be things like weight loss, particularly sort of individuals whose BMI exceeds 30, particularly if it exceeds 40, avoiding alcohol, which can be a very difficult thing, but at least cutting down, smoking cessation. What I don't have here, but also sleeping position. So a lateral decubitus sleeping position, individuals tend to snore less. When I snore at night, I never snored until 10 years ago. My wife, she will kind of ask me to kind of roll over or just kind of gently. She doesn't push me out of bed, thankfully, but she kind of rolled me over on my side, and she claims that I snore less. She can fall back to sleep if I snore less. Dental appliance, where you actually, if the cause of the obstructive sleep apnea is something, resulting from the jaw position, some of that can be addressed through a dental appliance. And then the UPPP, where they actually will laser off the uvula. Uvula is someone opens their mouth, you see the little, looks like a punching bag. And when I was a kid, we call it the punching bag at the back of the throat there. They will actually laser that and some of the associated tissue off, and relieve some of that potential obstruction. For the dental appliance and the surgery, they really need to determine, it worked for some people, it doesn't work for others. That, if the uvula and associated tissue are part of the problem, then the UPPP may be helpful. If not, it's not gonna do much. It's also it's a benign surgery, but that area of the mouth is pretty innervated, so it can be kind of painful. Some of the treatment and prognosis, if the individual gets the appropriate therapy, and again, most commonly the positive airway pressure, but the ones I mentioned, plus I'll talk about one other. So they'll see improvements in both subjective and objective tests of sleepiness. So individuals, they claim they're less sleepy. Okay, evaluation of attention-based cognitive outcomes. There's much more modest improvement. So there's improvement, but it tends to be less demonstrable, if you will, than some of the other improvements. Quality of life, large impairments in sleepiness and energy related to quality of life scores show substantial improvement. So quality of life overall, when you're not just looking at one particular thing, you're looking at how's your life overall, looking at a bunch of different factors, aggregating those, and there seems like there's a lot of potential benefit that's there as well. I will tell you this too. So I did home care many, many years ago, and I did a lot of BiPAP, CPAP, non-invasive setups with patients, and we did a lot of follow-up with them in the day. And it was amazing to me that individuals would report, if we can get them to be compliant, that was the big deal. If we can get them to be compliant, then we found that individuals would say that they felt better, that they no longer had that headache in the morning. They no longer were as irritable. They had more energy. It was just this, and these things kind of crept up on them over a period of time. And they found that, by again, kind of getting this sort of intervention, this, again, BiPAP, CPAP, weight loss, the combination of different things, surgery or dental appliance, by combining those things, they would often improve demonstrable and mainly expressed in terms of quality of life, kind of a confluence of several things, several improvements. So some of the metabolic effects of Babu 2005, again, I'm going to, interest of time, I'm going to skip down to the middle left, that there were significant reductions in glucose values. Okay, only 25 patients, so it wasn't this huge study. All right, but I will tell you there's other studies that have had similar findings. Harish in 2003, the outcome was insulin sensitivity significantly increased at 2 days. So it was the glucose values were more normalized, and the insulin sensitivity improved after a very short period of time. Okay, so it's, some real nice findings there, real positive findings. So some of the treatment prognosis with hypertension, and again, I'm looking at this one particular study, it randomized, double-blinded. So it wasn't a huge study. It was only 46 subjects, all right, 46 individuals, but it was randomized. You flip the coin, they went into this group or this group, double-blinded, where the individual and the researcher didn't know whether they were getting the placebo or they were getting the real deal. And what they were comparing were basically three groups. One group that had 2 weeks of CPAP, one group that had sham CPAP. So it wasn't CPAP. It was like maybe a mask that had air entrained into it. Okay, and no positive pressure, just air. Okay? A lot of air, a lot of 21%, making sure they weren't rebreathing the CO2, et cetera. And they were told it was CPAP. People had never had that before. And then the third group was just supplemental nocturnal oxygen. And it found out that the CPAP therapy resulted in a significant reduction in daytime mean arterial diastolic systolic pressures. Okay. What they also found was that in comparison to the sham CPAP, they found that the nocturnal supplemental oxygen therapy improved saturation, but did not affect blood pressure. Treatment. So really, this slide is saying that it was actually looked at, Sejkov and others really looked at, the effect that it had on, potentially on core pulmonale. And the take home from this was, if someone's compliant, has OSA, they're compliant with their CPAP or BiPAP, it addresses the hypoventilation, can reverse some or all of the pulmonary vasoconstriction, and basically decrease the right heart preload, and eventually some of that core pulmonale, the actual hypertrophy of the right ventricle, can also be reversed. Quick case, we're coming down the home stretch here. 63-year-old morbidly obese male presents with chief complaint of orthopnea, frequent urination, excessive thirst, chronic fatigue, et cetera, et cetera. And so it seems like he's really, he's wake up in the middle of the night, frequent urination. Really, what they're getting at, this case is getting at, is the patient probably has some form of diabetes or undiagnosed diabetes. They have chief complaint of orthopnea, so they don't sleep well in a lying down position. They may have some right heart involvement. Wife indicates that while sleeping, the patient snores very loudly and sometimes stops breathing. The exam, so the bilateral breath sounds basically equal, clear, but decrease at the basis, so maybe they're hyperinflated. Vital signs, mild hypertension, otherwise within normal limits, WNL, within normal limits. Notable labs of glucose is 256, so it's elevated more than twice what it should be, and as is the hemoglobin, which is kind of interesting too, because this individual may, because, and again, I'm supposing here, but in the context of the presentation, if they indeed have untreated OSA, what the body will do, because if it's severe enough, is that they're desaturating many times over the course of the night. So the body will develop secondary polycythemia in a similar way, different reason, but similar, if you will, magnitude to what an individual who has COPD will. Okay, so they have chronic hypoxemia, in one case because of COPD, in another case because they have untreated OSA. The body will build more red blood cells in order to compensate for that. Good news, bad news. Good news is you have more red blood cells. The bad news is the blood viscosity is thicker, and it further can exacerbate core pulmonale, because now that right heart has to not only pump against more resistance, but also what they're pumping, the blood is thicker, so it's more viscous. That's actually a word, I didn't make that up. Viscous. Chest x-ray, clear lungs, moderate cardiomegaly, so the heart looks like it is enlarged. Like the plan of care, sleep study, referred to a diabetes clinic, nutritional services mainly so they can get on a diet so that they can get their BMI closer to where it needs to be. I did want to share, a slide or two with you. It's not new news. So about 2014, Strollo out of the Cleveland Clinic did a study where they looked at individuals who had a lot of these, they had hypertension, they had diabetes, they also had, they had obstructive sleep apnea, but could not tolerate, for whatever reasons, the positive pressure treatment. Okay, so they had a lot of the, if you will, sequelae. Okay, their quality of life was not good. They had, again, the diabetes, et cetera, high blood pressure, maybe some cardiac issues as well. But yet they were in that terrible place where they couldn't tolerate the CPAP, okay, because of claustrophobia, for whatever reasons. And they did a study where they looked at this implantable device. okay, which is a nerve stimulator. It senses diaphragmatic excursion. When that is happening, patient's starting to breathe. It sends a signal and stimulates the upper airway muscles. And its bottom line was it's deemed very, very effective. This is not a lecture on it alone, but I was revising a chapter for one of my textbooks in 2014, 15, 16, and I almost stumbled on this article, and so we actually added sections to this chapter that talked about this, and now it's not the standard of care because it is an invasive procedure, okay, but it is absolutely commercialized. It's available commercially. It's not a panacea, but it's been reported with pretty good results. Other considerations for the future coming down the home stretch: should we consider wider OSA screening? I tend to be a fan of it, particularly now that a lot of the screening is starting to be done outside of sleep labs, and the company, the home care company, whatever, once the doctor prescribes it, will then send the sleep study equipment out, and then it'll be like a split study where the individual will be hook themselves up honestly. Or get some instructions, some virtual time, get some instructions for setting it up. They go to sleep, they get evaluated for a home sleep study, and then get the therapy that way. So maybe we should be testing a wider base of individuals. What are the long-term effects of OSA treatment in terms of cardiovascular morbidity, mortality? So that's something that's still to be looked at. We know that, for instance, there's a blood pressure can drop, depression can be reduced. Anxiety can be reduced. Diabetes and high blood pressure can be addressed as well. But does that mean that the patient, the mortality is better? Probably does, by the way, but we don't know for sure. Which intervention for OSA yield the highest benefit and at the lowest cost? Where's the greatest value? It's really critically important as well. Some take-home points: OSA is complicated. Neuropsychological changes affect quality of life, affects other things as well, including insulin resistance and hypertension, indirectly implicated in cardiac and vascular disease. But the good news is that treatment is out there, both in terms of positive pressure, surgery, even these implantable devices. But still, more work is yet to be done. And with that, some selected references here. I want to thank you guys for your time, and I hope you come back and you join us again. Thanks a lot, and have a wonderful day.